Good morning, good afternoon, and good evening. Thank you very much for the opportunity to introduce clinical message capability designed to transform bedside care. Clinical message was developed as a cooperation between QRS and the Center for Innovation in Complex Care, University Health Network, an affiliate of University of Toronto in Canada. The purpose of this video is to give you an overview what is clinical message capability all about. Before we begin, let's understand what is a clinical message. How does it improve the quality and economics of bedside care processes? What is the architecture of clinical message capability? And I'll give you some overview of some sample processes that are automated within the system, such as handoff, message lifecycle, nursing handoff, ED wait time, and many more processes. And I will discuss with you how do you go about implementing methodology like a clinical message, and how do you create a learning organization as a result of a clinical message capability. When we started architecting clinical message, there was some fundamental principles that had to be kept in mind. One is that clinical message content is created to communicate. It's not to become a clinical documentation. And secondly, electronic health record system, the EMR, is the master source of electronic data. Thirdly, a clinical message will extract information from EMR when needed and augment that information for the purpose of communication. And fourth point of that architecture is that we should have a view of the patient beyond the patient's status in the hospital or registering system. For example, if the patient is discharged and there's still pending activities the doctor needs to do, how does a doctor keep on top of those patients as opposed to in the system, as opposed to keeping in his daily notebooks? One of the core competency or core capability of a clinical message is the underlying communication platform. What we focused here is that not that message is a guaranteed delivery from one clinician to another, regardless of the device that they have, that the underlying medical issue is resolved within the agreed or clinically agreed time frame. Now, second thing that we focus on this thing, when a message is created, and at the point of message creation, we point out what is the accepted service level agreement that is associated with that message, i.e. by which time frame that underlying clinical issue must be resolved. So sending clinician can create expectation, and receiving clinicians can have a multiple views of that message. They can have a view and resolve their own messages. They can resolve in team messages, and they can receive the messages as the word-based or within the disciplines. One of the things that it does is that now with all the messages being electronically available, then it truly allows an interdisciplinary collaboration around a specific patient and a medical issue. And one of the third and fourth component of this thing is that communication has to be a device independent. Regardless the device that mobile clinician is using, iPhone, tablet, BlackBerry, pager, desktop, regardless of the device, whatever the device is the clinician is using at the time, system should use the appropriate device because the clinician's presence has been identified in the system. Second essential capability that clinical message brings into is a patient list. Patient list is automatically built from a registration system. What happens is that when a certain ward is associated within CM, and CM automatically pulls all the patients that are on that ward. And once the patients are pulled into CM, then a system automatically keeps the two systems in sync. And next thing what happens is that now is that once I have the patient, now I can dynamically associate clinicians to the patient and build a dynamic and collaborative patient care team. Once the patients are identified and the teams are created, and now as a physician can create a handoff, a significant pieces of information that needs to be communicated from one shift to another, and that list could be maintained during the shift as opposed to having to do all that at the end of the shift. And a physician can communicate the care plan to all team members. And at the beginning of each shift, the clinicians, as they sign on to the system, and they identify who is the most responsible clinician for that patient at that time. So what that does is that it gives a patient an electronic view of who are all the care members of the care team, and include their photographs and so forth. So therefore, if there is a people walking around in the halls, so other clinicians can identify who are the members of the team. And then last part of this thing, care teams are self-built and self-directed, and from all the simple communication protocol that is communicated through the physician, through the nursing staff, and all the care members. One of the probably most complex handoff process in any hospital is the nursing handoff. It's a frequently used nursing cardex. What we did in this system is that we allowed nursing staff to dynamically create their cardexes, and then once the cardexes are created and then associated with the specific patient, and then all the information that previously exists in the system is pre-populated. So therefore only a fraction of the data have to be populated by the nursing staff. And once that at the end of each shift is a snapshot is taken, and that snapshot is recorded as a cardex for that patient, and history is kept. So at any given time you can see snapshot of all the information electronically associated to that patient. But as the data is changed on the cardex, and that data is kept together for the purpose of analytics. When some elements are identified on the cardex, and nurses can associate alerts to those pieces of information, that when that certain condition meets, then nurse will automatically get notified through SMS or page or any other method of choice, is that there's certain activity has to be taken. So what this thing did is that it took a very manual cardex process and automated it, but automated it in a dynamic way that the math system doesn't limit the changes in the process dynamically. One of the most significant capability that was built on a communication platform was to influence emergency department wait time. We did that by focusing on improving consult time. So what happens in emergency department, and that the physician is able now to map his diagnosis to the policy and apply certain filters to identify what is the right service that must be involved in order to diagnose the patient properly and then decide whether the patient should be admitted or is discharged or provided some referral care. What this does is that now that automation enabled the physician to capture all the necessary information and the communicate that information and to the right service. Now, if the service on the other side isn't available, then system automatically escalates and finds the right person who can provide the insight to emergency department physician. Now, if it turns out to be that the patient is not to be admitted but to be referred to a outpatient clinic, and then the system automatically allows you to create some referrals and keep history of those referrals for the future use. What it did is that it significantly reduced the consult time by establishing a service level agreements for various services that are part of ED wait time, and as a result of this thing, we are able to significantly improve the consult time and improve the ED wait time in all emergency departments. One of the key requirements of clinical message system is that we're going to standardize and automate many processes that are taking place at the bedside care. Now, in order to standardize those processes and integrate them, we had to make sure is that they are actually producing the right outcomes. So in order to produce that, we had to build a real-time analytics system. What happens here is that now we look at all the analytics that are captured from the system, and we take two perspectives on that. One is the quality of care, and secondly, economics of care. And we have a pre-built analytics capability where you can slice and dice the data in many different ways to understand as to what is the impact of standardized and integrated process on the quality of care and economics of care. And what this does is that real-time data influences the clinician behavior and patient behavior and the others. And what the third part of this thing is that system then is able to adapt or configured to change, to manage the changing processes. So there's a inherently built-in continuous improvement where system is allowed to change, and real-time analytics identifies whether that improvement or change in the process actually resulted in any significant improvement. So how can a clinical message team help you? We can do a number of things for you. We can help identify or create a business case for you. We can build a consensus with all the stakeholders and ensuring that the standardized process is actually acceptable to all the different disciplines. We have a proven methodology that allows us to implement the systems and integrate them right into your environment and work with your team members to ensure not only they can accept the system, but they can actually extend the system on their own and monitor the performance of their standardized and integrated processes in real time. Lastly, I wanted to thank you for your time, and I hope this video was informative, and I hope we hear from you soon. But if you want more information, you can visit us in www.clinicalmessage.org, and you have a whole series of blogs and posts for you to review and understand is what our other people in your industry are doing in the same area. Thank you very much. Bye-bye.